welcome to Long COVID Foundation podcast. This is the channel where we share educational information on long COVID to help you understand your symptoms better. If you are new to the channel, make sure you hit subscribe button because it will help me to get answers relevant to your symptoms. In just a moment, we'll have an interview with Dr. Abdul Mannan Baig on variety of treatments in long COVID. So please watch this talk from start to finish because it will help you to learn more. What you will hear tonight is not personal medical advice. Take this information and share it with your practitioners. We are a registered charity offering education and information. We came together to share information and raise awareness about this debilitating condition. We rely on your donations and we thank you to all of you who donated. As a result, we managed to bring more experts on board, share educational information, create more content for you. Thank you, and let's jump straight into our discussion. Hello and welcome to our live streaming. And I would like to say that we are streaming on YouTube channel, on Twitter, on Facebook, on Facebook page, on LinkedIn. So wherever you are, just follow this information, click on subscribe, share and like. So everyone is welcome today, and we will have a very detailed discussion with Dr. Abdul Mannan Baig on variety of long COVID treatment options. So everyone who is here tonight will have an opportunity to ask questions, but first it is my pleasure to welcome Dr. Abdul Mannan Baig, who is a medical doctor and scientist from Pakistan. He has served as a physician in internal medicine at the University Hospital after his graduation from Leo Galland Medical College in Pakistan. He earned his PhD from the University of Sunderland in discovery of novel drug targets in eukaryotic microbes. After the outbreak of COVID-19 in early 2020, with his research experience and interest in targeting microbes, in the past 2 years he has published over 25 papers on COVID-19 and SARS-CoV-2. His research paper published in March 2020 was the first to hint the neuroinvasive potential of SARS-CoV-2 adopting to nasal route to the brain. The paper alone has amassed over 950 citations till date. His other papers on COVID-19 and SARS-CoV-2 focused on clinical presentation, treatment modalities, and targeting vital targets in SARS-CoV-2 caught attention of international news outlets and researchers worldwide. Recently, he has published on neurological deficits in long COVID in Nature. Dr. Baig is the recipient of the National Research Productivity Award from Pakistan Council of Science and Technology and the Award of Excellence in Research from Aga Khan University. Dr. Baig is the recipient also a scientific and medical advisor for Long COVID Foundation and Long COVID Coalition. He is also a vocal advocate of long COVID recognition and treatment acknowledgement by healthcare bodies and national health agencies at several social media outlets. Dr. Baig, it's such a pleasure to have you again on our channel.
Thank you very much. Thank you very much. And first of all, let me begin by thanking my followers and the listeners, who could log in today. I know this is a broadcast, that's happening at different times in different countries. So thanks to all of those guys who have managed to log in. Otherwise, you can always see a recording. Secondly, I would like to thank the Long COVID Foundation and the coalition that they bring about these discussions so that these things can be brought to attention of the public and the peers, and that enables us to deal with these problems firsthand and try to know the problems of the public in general. So thank you very much, and always a pleasure to be a part of Long COVID Foundation interviews.
Thank you. Likewise, we are very pleased to have you on board, and I would say huge thank you for contributing to the knowledge in neurology, and there are many links in the past where we discussed neurological issues with you and had roundtable discussion. So everyone who will be interested in that, there will be links below this video. But today we have another challenging topic to discuss, and which is variety of treatments in long COVID. So many of our listeners raised questions already, so we will keep them till the end. And now the floor is yours. So I will look forward to your presentation. So feel free to share your screen and start.
Sure. And I'll begin it with the page number one, okay. And before we go to the subsequent slides, okay, I would like the listeners and viewers to know that though it would go slide by slide, but then we would be avoiding reading each and every line from the slides, okay. That each slide gives me a stimulus to talk about the treatment options that are available. Those who are interested in the presentation and some nitty gritty details, okay, given in those slides, okay, can always get this presentation from Valentina from the Long COVID Foundation. So let's begin with slide number one. Now, just to talk on what should be treated in long COVID is a very important topic itself. Now, why I say that is that not all the patients with long COVID actually present with similar symptoms, though they have features in common. But then some of them are dominated by thrombotic issues and coagulation issues. Okay, microclots they call it. We'll talk about that as well. And others have got neurological problems, and as you can see, some of them have got a problem with the residual virus. Okay, they keep on testing positive for SARS-CoV-2 again and again. So these slides will walk you through different treatment options for not only the prothrombotic states, the hypercoagulable state that's causing the clotting. We'll talk about neurological issues, okay, what drugs and what treatments could be given, and the residual virus, which is my favorite. So let's move on to the next slide, where I disclose that the concepts and the ideas and the drugs which are named here are already a concept of the presenter, and they have been deposited at ResearchGate, and a DOI has been obtained so that any peer or researcher want to continue them, they can have my insights into it, so it's free to public. Now, having said that, okay, I move to a very 15-second thing on my experience with COVID-19 and long COVID. So, as Valentina has already mentioned, I would not take much time on this slide. Early in March 2020, I brought many what you call as pathogenic aspects of SARS-CoV-2 to the attention of my peers and the public in general and the healthcare agencies, so that we could not consider this virus as a benign entity, and we won't consider it as a conventional flu, because it's so very wrong to actually say that it's a flu, because by now, okay, everybody realizes that even if it's a flu, okay, it's a very malignant flu, okay. So SARS-CoV-2 is no way a benign or a very harmless type of pathogen that we know. These different images that you see here are related to whatever two cents I have contributed to the SARS-CoV-2 and COVID-19 research in past 2 years. Now, having said that, we take you to this slide, and this one is from a source which is already detailed at the bottom. Here we talk about how and what approach should be taken in order to assess or gauge the patient's suffering. You can see from grade 0 to grade 4. Okay, that depends upon the mobility of the person with long COVID and ME and CFS, and this applies to long COVID, yeah, but then it's equally applicable to other chronic illnesses, okay, which we'll talk about a little later. So this grading is what caught my attention, and it's actually very practical, to be honest, and the grades of disability in post COVID-19 for patients, okay, or long COVID patients could be from mild to very severe. Now, the grade 4 says severe functional limitation. If I could add a fifth one, okay, that would be most severe functional limitation to the point of disability. Now, I don't see it here in the slide, but already I say it with a very grief heart, that patients have gone into something which could be called as grade 5, because I yesterday on Twitter, had a DM that you're talking about. They are talking. I'm not talking. I'm like, guys are talking these days about exercise in long COVID, that it would do good. Okay, the a person who DM'd, okay, said that she couldn't even walk to her kitchen, okay, which is 15 steps away. Now try to understand that that's not severe. That's very severe. So there should be a grade. So this slide actually, you will have this presentation. You can see that where your colleague or you yourself, okay, stand in grading point of view. Takes us to the next slide, where I would show you the approach. Okay, this is a BMJ article that actually brings our attention towards what actually is needed to gauge the functional status of the patient and the severity of the disease status of the patient, that you can see on the left hand side, that the investigations should actually determine that what actually is the status of the disease. So all of these, okay, I would not read them one by one, but you can see is actually needed to gauge that what impact the COVID has on the life of patients with long COVID. But then there are certain stages, okay, in which a referral is needed. A physician, him or herself, cannot manage them. You can see that on the left hand side, in the orange rectangles, and safety netting and referrals. Now, it's not the PO2, okay, which when falls to 96, it's worrisome. But then sometime it could be complicated by massive pulmonary embolism. That's the movement of a clot in the lungs, okay, one of its vessel blocking it, and it can cause sudden cardiac death. Number two, you can see on the cardiology side, okay, it can cause an infarction. We know it. It causes pericarditis. It inflames the heart muscle cells and also causes heart failure. So if these are the things, okay, which are the patients are going through, okay, that's not a treatment which can be given on outpatient department basis, okay, needs hospitalization, needs special care. And then the one which is neurology. I've seen guys having neurological deficits, and to the point of having even delusions, deliriums, memory losses, and that does not comes into this section of referral. This is for guys, okay, who suffer acute respiratory shutdowns due to neurological issues or seizures. The neurological issues should be managed more by an hospital. Now, what you see on the right hand side, and it says investigation, and what I saw missing, and you can clearly spot that out, that it's added to the slide, is a factor known which is at the bottom, called SARS-CoV-2 PCR test being positive. Now, I don't know, it got omitted from the original publications. I had to add it as a supplementary thing, because many of the patients with long COVID, okay, should not be just like thought of there are many schools of thought who think that the virus is gone, and the disease now is a consequence of whatever it caused. Many patients, not few of them, many patients are continuously turning out SARS-CoV-2 positive in between the illness of long COVID, and that test should also be added to the investigations that we routinely do in patients with long COVID. The rest of them above, you already know them. I have spotted troponin especially with the star, because that gives you a guide that your heart muscle cells are damaged. Either it's an infarction or myocarditis. I myself had episode of chest discomfort. Okay, my troponin levels were 6 to 10 times higher. So it's not that I had it. Okay, the reason I'm spotting it, it's an end organ, and any uh, investigation that actually spots something gone wrong with the heart muscle cells and myocardial cells, okay, is cardinally important. So if your troponin levels are appearing high, you cannot sit at home, okay, you just have to go for a hospital admission, okay, that what this slide says. Now, one thing you can spot here on in this slide, and I'm taking time on it, is because the prothrombotic states that is mentioned here, where the mouse is moving now, actually requires treatment. And many FRSs, what you call as bodies are actually doing it. You can see SARS-CoV-2 PCR test positive should not be taken very casually. Okay, it needs to be addressed by some antiviral agents. The reason I call it the treatment three modality. And for neurological thing, I would also in this presentation talk about what drugs or herbs or antioxidant or anti-inflammatory things could be given. So this slide actually prepares you for the treatment modalities, that what should be addressed in long COVID. So in long COVID, prothrombotic states are the ones which need attention, and they actually call for treatment modalities. SARS-CoV-2, if it's turning positive repeatedly or due to reinfection or reappearance of the virus, okay, from its residual site, needs a treatment modality. And the neurological side, okay, should not be taken very casual. I'm saying that because most of the time complain of a brain fog or inability to compute simple words in communication are taken very casually. They are not that very what you call as casual stuff as considered. Damage to some very cardinal areas of the brain can actually cause that. So when you say brain fog, okay, I call it more a cognitive deficit rather than a brain fog. Brain fog is an expression. A cognitive deficiency or deficit is actually a neurological event, okay, that needs to be addressed. So we'll talk about these three things today in my presentation. I take you to the next slide, okay, which we talk about the prothrombotic states first. Now, the question is why prothrombotic states are so very important to be addressed at number one. I'll tell you the answer to that why. Because a vessel, okay, supplying any organ or a tissue of the human body, if compromised by a thrombus, the organ is like either would go into ischemia or infarction. The difference is that from ischemia you can recover back, okay, but from infarction already means the tissue has died, so coming back from that is not possible. So the reason the prothrombotic state, okay, need an immediate attention is the fact that it could compromise the function of any end organ of the body, be it brain, heart, lungs, kidney, okay, you name it. I mean, like a lack of blood supply is one thing, okay, which any organ would not tolerate. So the prothrombotic states are being considered at number one. We take you to the next slide to show you that what actually is known about it. And so here I put it in a way that prothrombotic state, okay, you can call it a no to long COVID, okay. So here you see that there are some conventional approaches, and they are being used at present as we talk, okay. You can see on the left hand side there is a preventive attempt that can be done by list of drugs. I'm not going to read them all. You know that they are known as antiplatelet anticoagulation triple therapy. If you don't know it, okay, you can ask your GP that what drugs are given to prevent the formation of a thrombus. And be very mindful that I'm not using the word clot here only because formation of a clot after getting a cut is a physiological thing. So it's normal. If you get a clot, okay, after a cut, it's normal. But having a clot in the circulation, okay, without the endothelium being damaged or without bleeding is called as a thrombus. So it's a technical term, medical term, but then it should be very distinctively used, okay, very carefully used, because saying that I developed a clot in my circulation is a bit confusing, because clot is a clot, and clotting is a normal phenomena. So in most of the presentation that I will do today, you will notice that I will call this mass as a thrombus. So preventive drugs. I mean, you don't allow that clot to be formed, okay, by the list of the drug that you see under that heading. Then there are drugs, okay, that if a clot has obstructed some circulation, those drugs can go lysate. You can see the name of them, okay, under the list of thrombolytic drugs on the right hand side here. And these are only 4 or 5 of them, okay. There are other members of the group which can go and actually dissolve the thrombus. Again, notice I'm not saying clot, because that pathological thing is more a thrombus than a clot. So this is what the conventional therapy is doing to prevent the clot formation or the thrombolytic drugs to dissolve it. One line of caution here, okay, for many of the listeners, and I know that many of you are on these medications as we talk. Never ever stop them abruptly, okay, or suddenly, because they have to be curtailed, and they have to be, if you're shifting from one type of therapy to other, okay, be it from a conventional allopathic medicine to a herbal one, you cannot drop these drugs immediately and shift to that, okay, because you have to curtail them, otherwise there is a rebound thing. The clotting actually cascade gets activated to form a thrombus then, and you could be in trouble, okay, if you stop them immediately. So one line of caution on this one, and then I take you back to what other things could be done to actually prevent the thrombus or lyse it. Now, this is one of the slide, okay, which many of my Twitter followers, okay, know that was presented to a few biotech companies, and many of them asked me last night that would you be actually presenting them as well to the public domain. So here it is. So in a conventional pharesis, okay, a pharesis, what you do is that you take blood from an artery, you actually rush it, or you actually make it go through a chamber, okay, where there are heparin beads. The heparin beads hold the SARS-CoV-2 at its S protein, and the blood that enters into the vein, okay, and gets back into the person's circulation is then devoid of the SARS-CoV-2 because it's being held by its S protein by the heparin beads. Heparin also causes an anticoagulant, what you call as effect as the blood passes. So in either way, it's helpful. Now, I actually, to those biotech companies and the other resources who wanted something novel to be added to it, okay, I suggested there are three options. One of which is that you can add ACE2 protein to the chamber, or NRP1 protein, which are available commercially. They additionally make it like very certain that the spike protein of the SARS-CoV-2 and the virus itself gets fooled, and it actually binds these proteins so that the blood that enters back into the general circulation has got a ghost protein attached to the virus, and it actually could engage the virus with dust, or I call it the dust of ACE2 and NRP1. So that renders it non-pathogenic. So when it enters into the vein, that virus is no more capable of binding to human cells expressing NRP1 and ACE2. The second thought was, I actually like this one more than the ACE2 and NRP1 protein dust, is that a drug could be added to the chamber, which actually binds either to the SARS-CoV-2 protease or more likely to the S protein. You can see the protease at the top, and the drug bounded in a circle, okay, below to the S protein, in the image just below it in the ribbons. Now, one thing very I want you to understand that, and it's a general knowledge as well, that the virus is very smart, in that when it comes close to a human cell, what it does is that it actually opens up itself, okay, to reveal its portion known as RBD, that you can see here in the diagram which is at the bottom. So if you see heparin beads, okay, do the trick by fooling the cell that it's close to endothelium or some human cell, and the moment it comes into contact with it, okay, it reveals its RBD, which is shown here in brown color, okay, or reddish color. If I don't know how it's appearing on your screen. So in the molecule of the S protein, if you can spot brown color or reddish color, okay, that's the RBD. So I call it the jaw drop, clap the tongue concept, that you make it drop the jaw by showing it heparin, and there are many published papers on it, that if it comes close to heparin, heparin actually fools the virus that it's a cell, and then it opens its jaw to show the tongue. The tongue is the RBD or RBM, what we call it. The moment it does that, if we have got a drug which we know binds to the RBM, as shown here on the top half of the figure, it would go engage with the RBM and would render the virus incapable of infecting the human cell. Now, for the sake of argument, let's say we pass the blood from the artery to the chamber. The drug binds, the heparin opens the jaw. That means it opens the S glycoprotein. The RBD gets revealed. The drug, which is already present in the chamber, binds to the RBM. When this blood goes back through the vein into the general circulation, okay, what happens is that that virus now no more can infect human cells because the drug is actually bound to an area, okay, which binds to the ACE2 receptor. So this was novelty of this apheresis procedure that now few biotechs have, our companies are carrying it out, doing it experimentally after they had some few meetings with me, and this is being tested in vitro as well as it would be very soon available for the patients. So in this concept, the jaw drop is said to be when the S glycoprotein opens the RBD. The tongue is the RBM to which the drug goes and clamps it. And once the drug binds to this area, okay, the bonds would make it incapable of the S protein RBM to actually bind to ACE2 receptor, because it's this portion where you can see the drug being bound is actually the one which sits over that ACE2 receptor in human. So this was one of the concept that my followers on Twitter were very interested to listen to. The next one that I show you is actually the same one, okay, shown that how experimentally it would be done. So you actually take the blood out from an artery shown here on the top right side of the image where the patient is lying. It passes through a chamber that you can see the red blood cell, white blood cells, and SARS-CoV-2 holding those drug molecules, and the dust of ACE2 and NRP1 could be separated, and the blood could be sent back to the patient's body, which is devoid of those SARS-CoV-2 to which the ACE2 NRP1 or the drug is bound. So this is being taken by some biotechs who are actually working on it, and the early results are very promising. So this is an addition to the conventional apheresis technique that is being done nowadays in other parts of in many parts of the world, I should say. So I'll take you to the next slide where we show you some natural products that can be given either as thrombolytics or thrombopreventive agents. Now, this is a paper from one of my what you call as collaborators who are yet to publish it. The reason that the name of the plants have been hidden here, that would be very soon available, okay, because it's under review. So they just wanted me to present this slide, show that they did some clot lysis thing. Again, I'm saying clot here because they didn't try it on a thrombus. Thrombus is a pathological one. Clot is the one which is physiological after a cut. So they collected the blood after a cut, they let it become a clot, and then they tested extract from these plants, okay, the name of which would be revealed in 15 days because they are expecting this publication to come on PubMed as an open article in 15 days. And they saw that clot, which actually when within the blood vessel is a thrombus, gets lysed by these plants products. So one thing I want to say here, as I've come to the first slide of the natural product, is that there is a misconception in public that, okay, oh my God, now it's plant product, okay, that's going to treat COVID. Now, I want to make something very clear here, that some of the top-notch drugs, okay, which are very commonly used in clinical practices, are plant derivatives. I don't want to go into that list. Okay, aspirin is one example, and we have got another example of drug metformin, which is used in patients with hyperglycemia to control their elevated blood glucose level. Again, plant-driven. So that misconception that a herbal product or a plant product is a second or a bit lower, what you call as a domain of treatment, is a very wrong concept, let me tell you, because aspirin prevents so many heart attacks, okay, by keeping the blood diluted, okay, and preventing the platelets to aggregate. It's a plant product obtained from a bark of a tree. And metformin, okay, which is sold with the name of glucophage and many other brand names, okay, is again a plant derivative. These are top two of them, okay. If I had enough time, okay, I could give you 50 names of the drugs, okay, used as one line or the first line therapies in many life-saving diseases, okay, which are plant products. So till those big pharmas, okay, come up with some magical, what you call as anti-thrombotic or thrombolytic agents, these natural products could be sometimes, okay, very useful in preventing the formation of the blood clot, and in case of long COVID, the thrombus. So remember this thing, that if platelet aggregation could be prevented, okay, formation of fibrin meshwork and the subsequent events in thrombosis can be minimized. I take you to my next slide, please. Okay, and that one actually shows you herbal drugs, okay, which actually have been published, okay, on PubMed. These are the ones on which material is there. You can see the name of the drug hesperidin here. There have been clinical trials with it, and this presentation would be available to all of you through Long COVID Foundation. So you can just go and just see that what in publications have they said. What I read here, okay, that their anticoagulant and fibrinolytic properties were equal to urokinase and streptokinase that we use nowadays in dissolving the thrombi in the blood vessels. So these drugs, okay, though they are plant derivatives and herbs, okay, could be a near future, what you call as one-line therapy to prevent prothrombotic states in long COVID. Takes me to my next slide. Excuse me. Now, neurological issues. Okay, so uh, this one is though my domain. Okay, I more what you call as research over this niche of long COVID, but it's not exclusively where I want to see improvements, because in total, okay, when the patient with long COVID would improve not only on prothrombotic prevention, neurological sides, and as well as complication sides, that would be a real treatment for these patients. So I decided to actually talk about three of them, because they are claiming the long COVID patients and disabling them. Now, here, the question I wrote it for myself, okay, is that is there yet a treatment protocol for neuro COVID? See, answering any question related to a disease, okay, in form of any treatment which would be very effectively giving results, depends upon whether or not you know about the underlying mechanism what's causing it. I'm saying this because if you know that the diabetes is caused by deficiency of pancreas which are secreting insulin, then the insulin by injection would be the treatment, isn't it? So the thing is, if you don't know that what are the pathogenetic or the causative factors, okay, which are causing the disease, the treatment is just a wild guess. Now, why I'm saying this thing for neurological issues is only because if you don't know what the virus or the inflammation caused by it is doing to the brain, then you are in trouble. I mean, like, then you can't say that I could design a very effective therapy for neurological deficits in long COVID patients, only because if you know what's causing it. So, very briefly, I will talk about that. What are the mechanisms? This slide actually shows you that it actually is one of the first papers, okay, that I published and hinted that it's affecting the brain. Then there were following papers, okay, that actually confirmed it by enormous amount of data in patients with COVID and long COVID. Now, having said that, we come to a few things, okay, which are the first line problems of patients with long COVID. Dysautonomia is a dysfunctional autonomic nervous system in patients with long COVID. I mean, like, every other involuntary function that you used to take for granted, and we just like think that would routinely happen to us, okay, is seen to be compromised in patients with long COVID. You started from the diameter of the pupil, okay, that gets automatically adjusted to light going bright or light going dim. From here, you go right to the bladder function or the uterine function, anything in between, okay, including respiratory tract, which breathes itself. Now, I mean, like, just tell me that you're listening to this presentation. I mean, except for the patients, few patients with long COVID, okay, who knows that we actually took how many breaths in the last minute? We breathe 18 to 20 times and we don't notice it. It's a blessing. But that autonomic nervous system now is being tested, okay, by long COVID, uh, due to the viral persistence, which is my thought. I mean, like, we'll talk about that. But then just imagine that their heart rate when they're sitting, it's different. When they're lying, it's different. When they stand up, it's different. We have already seen this in ME and CFS. We have already noticed these findings in post exertional malaise in patients. Okay, why is this happening? I mean, like, long COVID is bringing attention to it, but try to understand that all of the organs that you see in this slide here, okay, ranging from eyes. Let me see whether we have labeled. Yeah, it's there from the top, okay, and go down to the organs like reproductive organs and everything in between, okay, which functions by its own, what you call as regulation, is affected in long COVID. We'll talk about the cause, but then first try to understand what a life it would be if you know that you are breathing each time you took a breath and rushed it out. Just try to understand that your heart is beating 72 times a minute, okay, if you're lucky. In patients with dysautonomia in long COVID, 130 at rest, 15 steps they walk, 170, touches 200 sometime. I mean, like, just imagine the enormous amount of discomfort they are going through. So this is one side of dysautonomia that they are suffering. I think that the residual virus or the inflammation caused by it is actually affecting centers in the brain and the cord in the thoracic region. And also, I'm like, I won't be surprised if I see a paper, okay, that says that the SARS-CoV-2 spike protein binds the neurotransmitter or the chemicals released by these nerves to regulate the body function in incoming month. I mean, like, because some of the papers that I have published with levodopa, which actually forms the neurotransmitters like epinephrine, norepinephrine produced by these nerve endings, has shown a very effective binding of that levodopa to the spike protein. So it's either it's binding the terminal molecule, affecting the cord, or affecting the centers in the brain. We have to have a way to address this. This inflammation either should be suppressed or the virus should be killed, so that the patient with long COVID, okay, come out of this dysautonomia as soon as possible. It's not the somatic organ symptoms that are bothering them. It's more about the autonomic nervous system organs that were handled by itself without letting us know. Okay, which now, when coming to attention, is actually making the guys sick. Now, these drugs that you see on the list, okay, and as I said it again and again, that this presentation would be available to you guys, okay, and from the Long COVID Foundation, are tried to stimulate the brain, lessen the inflammation, and there are growth factors even that can cause the growth of the axon and regenerate the neuronal terminals, not the neuron. Don't mix it here. Neurons cannot regenerate, but if it loses its structures known as dendrites or a long structure known as axon, we can cause regrowth of or potentiate the regrowth of those processes by growth factors. So all of them are under consideration as we speak, and there are scientists, okay, who are researching over the use of the list that you saw in patients with long COVID with the publication expected very shortly on them. That brings me to this slide, okay, in which you can see that neuroprotective effects of some medicinal plants, just like you heard me on aspirin, which prevents the clotting, again a plant derivative. You see, and metformin, okay, which is a plant derivative, prevents hyperglycemia and diabetes. These are medicinal plants, okay, which could prove to be neuroprotective, and they could prevent the apoptosis of the neurons, okay, that are undergoing the insult by SARS-CoV-2. So these all arrows point off towards the pathways or the ion influxes that can be regulated in order to stimulate the protection mechanism. I say it only because, and very carefully, because none of them can cause a regeneration of a neuron after it dies off. So these are the drugs. And for neurological issues, okay, you see here, okay, either it's a pharmacological approach, a herbal medicine, antioxidants, neurotransmitter agonist, and anti-inflammatory drugs seen on the right side of the slide, or it could be growth factors that you heard me can cause the regeneration of the axons and the dendrite. Stem cell, now I will be taking 1 minute here, okay, to caution you on this one. Stem cell, or if I use the word very correctly, it would be neuronal stem cells can regenerate the neuronal loss at an area in COVID or long COVID. But my question is that it's first very important to know that where the loss has occurred. Now, if the loss has occurred at the areas like midbrain and medulla oblongata, the brainstem, which are so much core areas of the brain, a transplant of these cells to those areas would not be possible. Even the procedure could kill the person. But if it's on the outer areas of the brain, like the cortex and other areas which are accessible to human hand, I mean, where you can implant them, maybe the stem cell therapy could restore some loss of gray matter in the cerebral cortex, the big part of the brain. But I'm very, careful when I say this, only because injecting it through a vein and just guessing that they are going to be pulled out by those areas which are having loss of neurons like a magnet, forget about it. It's not happening. It will go everywhere in the body, and even can give origin to some germ cell tumors, okay, which or some neurological, what you call as tumors, okay, which you don't know. So the hype is okay, but then there are other things which we know for centuries, like ginkgo biloba and CBD oils. They do some good to reduce the inflammation. They actually are antioxidants at the same time. So when the conventional medicine is not giving us that light at the end of the tunnel, okay, if a herbal medicine has been proven in the past to be of some value, okay, it makes its own place in long COVID. I'm saying this only because you see, if I would have been presenting these slides without the evidence of drugs like hesperidin gone into clinical trials, you would think that I'm some like herbalist, okay, from a remote, what you call as part of the world, okay, who doesn't knows what allopathic medicine is. No, it's not like that. Those drugs have been tried. Hesperidin has gone into clinical trials by more than three, what you call as the resources, and they have published their research on it. For others, okay, you have to make an individual search that what herbal or chemicals have proven to be antioxidants and anti-inflammatory. I'm saying this only because even if you take a year, okay, you won't find a drug or a chemical which is herbal and has played a role in regeneration of a neuron after the neuronal death. After neuronal death, regeneration of the neuron is not possible. It's a bad news, okay, but let me be very candid and honest when I say that. If you hear somebody says that I give you a drug, okay, that can regenerate a neuron, okay, foolish. I mean, like, it never was possible, never has been reported. It's only the stem cell that can do the trick. But you just heard me on the limitation with the stem cells, that if you want to implant it at an area, okay, which is very core region of the brain, the procedure itself could kill the person, okay. The stem cell would grow and replenish the neuron is another story, okay. It's a bridge too far. So let's take you guys to the last topic, that's viral persistence. Now, those of you who follow me on Twitter, okay, and they every now and then come across my quest to heal the patients with long COVID, okay, know that how much this factor is being emphasized by me. It's not uh, just an educated guess, that I'm a very what you call as a vocal advocate of viral persistence behind the cause. I've linked the dot very vigilantly in order to make this concept come and groove my brain. $1 million question. Okay, you tell me one thing. If you are having a fever, okay, close your eyes and tell me what you're suffering. Infection. So if somebody says that, your fever is only because the bacteria came and it left some protein, now those proteins are playing with your tissues and you are having fever, give me a big break here. I'm not a moron, I'm not buying this. Okay, so if somebody says that long COVID is like you still are suffering those same thrombotic complications, but you see the virus is gone. Now, excuse me, not the case, So either it's the virus that is still there, or the protein that it produces, the S protein and the other list of them are there. They are promoting the coagulation sequence, and the disease is still there. I mean, who says long COVID gives you an impression that okay, the short status has gone and now it's a long story? Forget about it. Nothing like that. Long COVID is the most active disease I have ever witnessed in my 30 years career as a scientist and a medicine practitioner. So if it's not active, okay, tell me how so many symptoms are active 24/7 in these patients. Okay, and where is actually the mild part of it? I mean, like, where is actually the subacute part of it? Where is actually the chronic part of it? I mean, like, it's not a disease which is at sleep. It's a disease which is very alive, and possibly the virus hides at some places in the body to come and replicate and trouble the immune system again. That actually is shown in this slide. Now, very recently, okay, scientists have spotted that gut is a reservoir for the virus, and there are some very excellent papers emerging on this factor alone. You saw this one, the sinus one, okay, on the Twitter. I posted it like 2 months back, that there are areas like in sinuses where there is no approach of the immune cells, okay, and it could evade very brilliantly by hiding itself in these sinuses, and then again come back into the venous circulation. Eye is another area where it can hide it in conjunctival sac, okay, and so if it hides, okay, how does it keeps the disease alive? It hides, it then reappears, provokes the immune system again. Immune system responds, patient becomes symptomatic. You call that disease as long COVID. I won't say it's as simple as that. It's very complicated, but then the virus is, and or the proteins that were produced by it are behind the story, okay. And then just wait for 6 weeks, okay, you will see papers on it from my lab, and other labs are 24/7 working on it. So how do you address it? And then please, just pardon me on that. I just move very quickly from this slide to another. Just try to see these leukocyte, the neutrophils, the lymphocyte, and we know that it enters into the lymphocyte by ACE2 independent mechanism. It persists there. This is another place to hide, and you see, I would like to. I mean, like, I'm amazed and dazzled that you go hide under the tent of an army, okay, that actually is built to kill you. Just see, lymphocytes are those soldiers. It's that army, that is actually programmed to kill it. And you see where it gets a refuge to hide, the lymphocyte itself. Now, just see how much it dares. I mean, like, it not only enters them, recent papers, okay, even in Nature, they actually also kill the lymphocyte. So this is a suicidal mission. I mean, like, it comes and it actually is now harboring within the cell that actually was evolutionarily designed to kill it. Okay, just imagine those guys, okay, who call this as a mild disease or a flu. I would like to meet them sometime and educate them. Okay, that tell me the mild part of it. Okay, I would do something from tomorrow other than medical practice and being a scientist. I don't buy that. Okay, see how brilliant it is that it actually is not scared of that lymphocyte. It goes, enters inside the lymphocyte by a novel mechanism, causes its apoptosis, and then ask me why so many people with long COVID are suffering lymphopenia. The lymphocyte counts in their body, okay, whenever counted, okay, by a lab, the count comes low. Give me an explanation. How and why they are disappearing from the blood. So you have to address the viral persistence. They had a drug, okay, which Paxlovid, okay, which actually showed some response for a few days, but then it came across that challenge that in long COVID patients, okay, there was a relapse and the virus, the symptoms reappeared. So it actually acts by paralyzing that same main protease that you heard me on the herbal page being done by hesperidin and other herbs. But then see if the disease is like showing itself again, it shows that in long term what effect this drug could bring. I mean, the mechanism is fascinating, but why doesn't it keeps up to that mechanism and fully eradicates the virus once and for all? Because this drug or any drug would only go to the sites where blood vessel would take it. If the virus knows places, okay, where it can hide, it can actually conceal itself where the blood vessels don't reach. Just forget about it, that any drug, okay, be it a product of a big pharma or a small pharma, is going to do the trick. So the reason some of you my post, okay, you saw on Twitter that I was a very strong advocate of cleansing the nose and having gargles, okay, so that these areas which are accessible to you for cleansing, okay, should be actually approached for reducing the viral load. And viral load is the third. I place it at number three, but then it's the third leading cause of long COVID. Okay, if you actually would I mean, try to conceive what I'm trying to say, that it hides. If it hides, okay, try to see what's accessible to your own approach to clean it. The nasal cavity, yeah, but don't actually rush the water too much to the area like at the base of the nose. Just conventional cleaning, okay, and gargles, okay, could actually reduce the viral load to less than half. And remember this thing, in the nose, in the mouth, okay, if it's a reservoir and it's a residual virus, it keeps on multiplying by coming in contact with the human cells here. So if you just like had a good gargle or a nose wash in 3 days, okay, it's possible that it would replace the original what you call as virus that you actually flushed. So keep on cleansing these areas. Gut could be cleansed as well with some probiotics and drugs and stuff. We are working on it. Okay, we'll shortly have a paper on that how to cleanse in the gut. So that should be the approach, I think, for viral persistence and its clearance. Now, this was the slide which I was possibly thinking that I forgot to add it, okay, which actually shows the literature and to some of my peers, okay, who actually I had a word last week. They said that, okay, so now you're a herbalist. So I say, yeah, you take aspirin for a cardiac, what you call as issue, okay, you are also a herbalist because that drug is also derived from plant. So just break that, what you call as misconception. A drug is only a good drug when it works, it shows off. Okay, so they have done, I mean, NIH has done trials. It's public here, and you can access that information. I think that some drugs like hesperidin and likewise drugs, okay, have got some potential that they would show in time. But then NIH doing a clinical trial on a drug hesperidin, if somebody says that it's a plant derivative and why is it being done, okay, when why don't you have some allopathic drugs on it, okay, just ask NIH, okay, they would be very glad to reply to that. So that takes us to the next one. Here you see is one of the docking results that we did on the SARS-CoV-2 main protease. We actually used a software, okay, and wanted to see where this drug goes and binds. It exactly occupies that area where the SARS-CoV-2 protease, okay, actually binds its active molecule. So the drug here you can see in the circles, benzene rings and red dots, okay, occupied the same area. So I'm very open to novel drugs and chemical and molecules, which does the same trick, okay, which is done by so many costly drugs, okay, manufactured by the pharma. So there are other molecules like hesperidin. This is not the alone. I just pegged it only to give you one example. So the next one is, let's see, so I don't know. This slide is possibly the last one. It was better placed where actually we were talking about the jaw drop and clamp the tongue concept, but then this was to show you that the drug binds when the jaw drops and the tongue is shown. I mean, heparin does it, and heparin does what? Heparin actually lowers the jaw because when it comes into contact with heparin, it thinks it's a cell. Once it opens the jaw, okay, the tongue, which I call as the RBM, this brown or reddish molecule is ready to bind to ACE2, and the drug actually binds to it, so it would prevent the reinfection and of the human cells once the drug is bound to it. So either you kill the virus or you render it, or I call it with a word like you castrate it. Okay, by engaging its S protein, it is no good. It's as good as a dust particle if you can engage its S protein with the drug, and if the bonds are good and the drug keeps attached to that area, then that virus is no good. Okay, to bind to any ACE2 expressing cells. Okay, I think this is the last slide. Thank you very much. Thank you for your attention.
Thank you so much, Dr. Baig. That was fantastic information. And as always, you present up to date information that is often is missing from many scientists. And I'm glad that at the foundation we are working 24/7 to research papers and produce up to date results so the audience stays up to date, as well as clinicians are aware of symptoms and mechanisms behind those symptoms. So we will have now a session of questions, and I think I will pick some of the questions that we had um, while you were talking. And one of them was person has got problems swallowing and can't focus in low light and has got brain fog. So, is there anything that you would um, guide in terms of the neurological path, or there is something else maybe going on?
See, the ones that I see on the screen, okay, problem with the swallowing. Let me tell you that this virus actually, whatever the protein it uses to enter the human cell, it's capable of causing infection of the upper respiratory tract, the pharynx, and the gut. So the swallowing problems that are referred here could be due to two things: local inflammation caused by the virus and its viral load, or it could be neural. Okay, that the nerves that supply the pharynx, which make us deglute, I mean swallow. When we do like this, the pharyngeal muscle contract and they go down, is actually controlled by some pharyngeal nerves. So if those nerves are involved and they are demyelinated, okay, this problem could be there. Can you show me the question again, please? Because there was a extension of brain fog and something else with it.
Sure.
Okay. Can't focus in low light. Now, just this, I'm very thankful to the individual who asked this question. Did you hear me in the earlier part where I said it starts from the eyes? Okay, where we actually in the low light, okay, adjust it automatically, and in bright light, okay, it actually narrows that pupil area. You are not completely being able to do that because of some autonomic thing. Your eyes are not adjusting to the light, so obviously you can't focus. And then the brain fog, you heard me on this. I was saying that brain fog is an expression. I mean, there is a neuroinflammation going on, okay, that actually needs to be halted or subsided, so you start feeling well. I'm not saying that I would name the drug here. Go to a doctor. I mean, like, he must be knowing a list of the drugs, okay, which are actually neuroinflammatory suppressive molecules. They should cross the blood-brain barrier, and they should make you feel better in a week. I mean, you should have that consultation in which you ask him that, could you name me a drug that you can prescribe, is safe, that can limit my neuroinflammation? Okay, you would be okay. Thank you.
Thank you so much. We also had some questions who reported on Twitter as well.
Okay.
But I think I will pick this question from the person in the audience, which is something that you discussed as well, talking about the apheresis.
Mhm.
So, is it something that you could comment on? What
Yeah,
is
sure.
the best
Now,
option?
uh, leaving that discussion that why these GPCR antibodies are being produced, okay, I won't like to go into that, for which we can have another session. I mean, and that would actually be more longer than this one. I would tell you only why these GPCR autoantibodies are being produced. Immunoadsorption is a classical way to actually, I would say, slow down. I would not say treat. And I'm very carefully choosing my words only because if I say it cures it, okay, it won't be correct. Because once you absorb them and remove them, that's a break for 3 weeks, something like that. And then your body again forms those antibodies because the SARS-CoV-2 has set the clock in such a way that now my own immune system is making antibodies against my own receptor. So the apheresis, immunoadsorption, whatever you get as a treatment is or plasma exchange, that's only temporary, okay? And I don't want to give you any false hopes here, okay? Because the factory inside, the spleen and the lymph node are going to make it again, you know? So there should be a permanent, what you call as solution to it, okay? Which in medicine, okay, we give corticosteroids, which are themselves not very safe. They cause edema and volume overload, and they have got their own side effect. They decrease your body immunity to infections. This should be an active area of research, okay, where how to actually address that auto GPCR antibody formation should be not halted, they should be cured. Because all these plasmapheresis and stuff does is that it gives you temporary relief, and 3 weeks you're back to square one.
Yes, actually, this is what we are seeing in practice as well, not just in theory, but in practical comments from people who had plasmapheresis and helpapheresis. They still have autoantibodies as well, and something is not really working well over there. So,
I'll tell you a game changer drug here. You know, a game changer drug for this condition, okay, would be a one that suppresses the formation of autoantibodies at the same time doesn't suppresses your immunity or predisposes you to infection. And it's a very active area of research. Okay, so whosoever asked this question actually is a representative of many of you guys who actually are suffering it. Don't be disappointed. Okay, it's a cutting edge area of research. We will have something in 6 months. Okay.
great, great. So, I will take the last question from the audience, and this is on stem cells.
Mm.
So, is it possible to cure if
Yeah.
it
And
happens?
this is a good question, and it was very intelligently put by the listener. Frontal lobe is very much accessible to the hands, surgical hands, and if you could spot that area in frontal lobe or temporal or occipital, okay, or parietal, that actually has got the loss of that gray matter, and precisely you know where it's the loss. This is a very promising procedure for frontal lobe neuronal loss, okay, because then the the niche. The procedure would not kill the patient, which I'm very worried about. Okay, when you do say stem cell in COVID, long COVID, yes, it can be possible to replace those cells in the frontal lobe.
Thank you so much. So I will cover now some questions from Twitter users who posted sometime before when we announced that we're going to have this live session. So the question is why the treatment for long COVID are getting so late. So we are now 2 years into pandemic, and we still don't have a unified protocol anywhere in the world. So there is no protocols yet. So why is this delay?
Now, I mean, I wish there was a very simple answer to this question, but I will use a minimum number of words and keep it concise and very what you call as exact what being asked. Try to understand this thing. SARS-CoV-2 infection step one. Okay, then you get acute COVID step two. Then your genetic makeup of HLA antigen, all the viral load, or your immune response determines that whether you will go acute, finish it, or you will go into long COVID. When you go into long COVID, now there is a branch. Try to understand, and that's from the skin, eye, brain, mouth, nose. You start making the arrows. Okay, cardiovascular system, renal, okay, endocrine system, GIT. Now, if for the sake of argument, let's say I make 50 branches of it. Okay, from chronic SARS-CoV-2 and then 50 branches. You don't know that some of the patients, okay, with branch number 2 would be the prominent one, rest of them would be mild. Some of them from the cardio side would be more prominent, some of them from the neurological side would be more prominent, some of them would have GI problems. Now, answer one question that I would like to ask very humbly. If this person comes to you, okay, with one of them dominant and the other not that dominant, okay, but then they are bothering him, for mass levels in the world, okay, how do you announce a treatment? Not possible. So in medicine, okay, I did it with some very good teachers, and long before it came in the book, they used to say that try to individualize your patient. Every patient is an individual, so it would then deserve an individual therapy. So if a person comes to me with long COVID, I would like to see what is the dominant symptom of those 50. I would treat
Mhm.
that first, go to the others, and there is no magic pill. One treatment, you will not get it in a century. I'm sitting here, okay, you can bet on, I would bet my wallet on it, okay, that you won't get a single pill for it. You have to treat those 50 branches, especially the one which is more prominent in the patient that came to you. So that's the answer. Okay, it's getting late only because of that. Because it's not like an antibiotic for a staphylococcus that okay, give this and all the staphylococci are resting then. No.
And I think in January we also saw that on long COVID there were only a few studies who trialed one or another solution again for very narrow um, symptoms. Rather than talking about the range of symptoms that people have. And another, I think, issue here would be that with acute COVID, you would see the results quite instantly. So in a month or 2 months or three
Mhm.
months. And then with long COVID, it takes quite a while to properly assess those patients. It
Very
takes
well.
time. So let's hope we're going to find solutions, not just for single symptom, but for a variety of the symptoms. And
And
as you mentioned as well, there are natural compounds that tackling variety of symptoms, variety of pathways, and one of them is hesperidine and baicalin and all these natural compounds. So it's not something that there is no treatment for long COVID, but maybe there is delayed research publishing that it can be applied on long COVID. So
yeah,
let's, yes.
I would just like to spread this thing through my listeners and the ones who will see this, okay, after it gets posted there. When you go to your physician, okay, and you have got long COVID, don't try to convince him that you have got long COVID. Okay? First of all, say him, treat me for the thing that I have come to you. Don't have to label it. Okay, if you are having clotting problems, say I've got clotting problems. Look at my D dimers. Treat that. Okay, so your dominant symptom, your dominant sign should be treated first, and then the rest of them can wait. Okay, and in journal, I'm telling you, the day we could bring that virus away from its hiding niche and kill it, okay, all of those 50 branches would squeeze to point number one and then done. That would be the magic thing whenever it happens. I don't know whether who would do it, okay, but if it could squeeze those 50 points to a single point and then make it go, if the residual virus is gone, the job is not half done. It's totally done.
Absolutely.
Thank you.
Very practical advice, and I'm sure people will consider it when they see specialists complaining, explaining your symptoms is the best option, maybe to start digging into your real issues. So, thank you for that. Let's move on. We have another question. So, what factors determine if someone will or will not get long COVID? Is it
Thank
genetic predisposition? Is it diabetes? Is it age? Is it gender? Is it ethical background? What it is?
And see, just when it popped out on the screen, okay, and I couldn't resist smiling on a thing because this is challenging. This is the day one this is a FAQ, So just let me be again. I will do the same thing. Minimum words, okay. Keep it concise and very precise so that I can answer it. Whether you will get long COVID or not, first of all, depends upon your genetic makeup. I was shouting this that the gene is called HLA antigen, HLA gene. It determines how much or the magnitude of the immune response that you are going to mount. Now, you have heard guys saying that this is a natural supplement. It makes your immunity very strong. Okay, so and your immunity then fights the pathogen so very strong. all layman thing. I'll tell you. The more stronger your immunity fights the virus, okay, the more is the likelihood that you would get a ventilator and die. And I don't need to convince anyone to actually say that I'm correct on this. The greater the immune response, the more the inflammation, the higher the chance of being dead. So we mount the immune response like this: acute, moderate, okay, mild to moderate, we severe, and amplified. In cases of long COVID, the and whenever it publishes, okay, you can alert me that it's on the PubMed, okay, so I would enjoy reading it as well. That these are those people, okay, who fail to mount a sufficient response to the virus to eradicate it. So when you just like don't mount even a moderate immune response, the virus doesn't get cleared. It gives the virus the time to hide, and then you heard me. Okay, what it does comes teases the immune system. So in the first attempt, okay, if you had a moderate, not a very brilliant or a severe immune response, but you had an immune response that was enough to clear it, okay, the guy would not go into long COVID. That depends upon the HLA genotype the person has got. Viral load is the next thing, that if the virus goes into the body and its load is high, the chances that it would find residual places to hide is high. So that would be factor number two. So yeah, and obviously other factors do count it, but my top two or three are these. Okay, viral load, HLA determination, and how HLA gene, the subtype you are made up of, that actually determines the whether you go into long COVID or not.
Thank you. And why do you think symptoms may vary so much among long COVID patients? And it makes it very difficult to find specialists for a long COVID patient when you have diversity of symptoms. It's not only breathing issues. It's a mess, and it's really difficult, and it's really hard for scientists to navigate what to do
Right.
with that.
You're right. And if I'm not wrong, okay, I heard you these questions were posted before our session began. So I think that if these questions were after the presentation, okay, I didn't see this one coming because they heard me on that one, that it's acute infection, SARS-CoV-2, residual virus, 52 branches, 50 branches, okay, cardiovascular, renal, prothrombotic. So the symptoms, okay, depends upon which system was affected the most. So if one system is affected the most, okay, the person is only going to complain about that. I know guys with long COVID, okay, who have got predominantly skin problems, web on the skin, okay, rashes on the skin. They don't complain much of the heart attack and pulmonary embolism and stuff. So it depends upon which part of your body, which organ of your body gets the major beating. And it itself is a random thing. Don't buy if somebody tells you that your heart, the SARS-CoV loves your heart. No, it doesn't. I mean, like if its loads first go very heavier into the liver, okay, the liver is going to get that hepatitis that we are seeing nowadays, like emerging diseases, hepatitis in children and worldwide. So it all depends upon where it is going. And if children's and guys are more ingesting it than inhaling it, the reservoir is gut, and from the gut, the blood goes to the liver, straight to the liver. So forget about the heart, okay? It's going to get the major beating to the liver first, and then if the person survives, okay, it would go to the heart as well. So the symptom variation depends upon which organ of your body randomly got the viral load.
So another question, actually, so very relevant.
Ah,
Why we see you have turned towards herbal and natural product treatment line?
uh, I again say the same thing. If this individual would withdraw this question if he heard or she heard the presentation. Herbal or natural and allopathic, newly designed, doesn't make a difference. The only thing that makes a difference is that is it giving a result? Is it with less side effects? If its margin of safety is good, if it's taken in a little extra amount, okay, it won't harm. So I didn't shift to anything. I'm just a very practical, what you call a scientist. I believe in if mango trees have got leaves, okay, and they are showing effects in long COVID and healing the patient, okay, I'm going to write mango trees, okay, and their powder for treatment of long COVID. So it should come with the result. So it's not a shift. It's just like the science I do, the docking studies. If they show that it's occupying the same niche of the the viral protein which actually is done by those multi-billion companies drugs, okay, I would say that it's doing sometime, the herbals are doing sometime much better, what you call is binding than the drugs which are manufactured by big pharma, and I would not hesitate to say that.
Okay, I see. So, another question actually on apheresis. So, you covered the process, you covered the novel apheresis technique. So, in terms of long term, is it a long term solution, and what to do in the long COVID management?
Yeah, I mean, like in FRSs, okay, is you heard me on this. Gives you a 3 week window period, maximum 6 week. Okay, it can vary, but then whatever is in your blood, okay, if it's being reproduced in your body, be it autoantibody, be it a spike protein, be it any other protein of SARS-CoV-2, if your body is actually making it again, okay, the pathology comes back. So in long term, I see something like a thing which actually addresses the root cause would be a major treatment modality. But then FRSS is like actually giving them the time to advise you the time to think over that what actually is good for me. Otherwise, without FRSS, okay, patients would be suffering.
And what should be primary target of any long COVID treatment regimen?
Today you saw RX1, RX2, RX3, three things. Address the thrombosis because it's very common. So 90% of the patients with long COVID at some level of their pathogenesis have got that. 60 to 65% of the complaints, okay, directly or indirectly are related to the neurological problems. So, I mean, that should be addressed. And what's hidden and never reveals itself, okay, I don't know how even I got a mind to actually get suspicious on it, is the viral persistence. If you just periodically do the SARS-CoV-2 PCR test or rat test in long COVID, okay, and keep on looking that whether the test is coming positive or not, okay, you'll get the answer. I mean, like that if it's coming positive, okay, tell me the source, how it's coming positive. If those guys, okay, who actually don't agree with me say that the virus is long gone, so this is long COVID now. Okay, so the virus is long gone. Okay, show me that the virus is gone. I'm going to buy it. Okay, biopsy of the gut says otherwise. Biopsy of the nasal sinuses says otherwise. Neurons have got it. Lymphocytes are studded with it. So is it gone? So is it, if it's gone, okay, why the lymphocytes are showing it? Why they are still going into apoptosis? Why my patient with long COVID are having lymphopenias, lymphocyte count go down? I mean, like, no explanation. So when you can't convince me, my top thing would be a drug maneuver or a treatment modality, whatever it is, okay. If it can flush the residual virus, it's not job half done. It's totally done with long COVID.
Thank you so much. That was really difficult question.
I know.
So thank you for covering this. And again, it's a little bit on the mechanics of the apheresis, I would assume. So what do you propose to add to the chambers filtering the blood?
See, I talked about ACE2 and RP1 used as a protein dust, but they are not my favorite. Okay, my favorite is a drug, okay, which could go and bind the S protein after the heparin reveals it, so that you. I don't want to use that word, but then SARS-CoV-2 has caused us so much pain that I really enjoy saying this word, that it would castrate the SARS-CoV-2, okay, by binding to the S protein, because now it's a virus that cannot celebrate. We will, because it can no more enter the ACE2 expressing cell if you engage that site with the drug, and the drug binds that area very, very, I mean, avidly. So yeah, I mean, if I could add something to the FRSS chamber, okay, it would be a drug that actually hugs that area of S protein RBM so very good that it doesn't leaves it, okay, and then the virus is no more good. It's there, but it's no more good. So if you can't beat it, okay, at least castrate it. So that could be done.
Okay, thank you. And another question is from your area of expertise. It's what neurological tissues are being targeted in long COVID patients and which symptoms can reverse?
See, in dysautonomia, and when I say neurological tissues, I even consider that neurotransmitter released by the nerve as a neurological component. So, if those autonomic functions, okay, their areas in the spinal cord and the brain are not that much a target, okay, the nerves are, as you heard with the question with pharyngeal difficult swallowing, who knows that that virus is actually binding that neurotransmitter released by that pharyngeal nerve, and the person cannot actually cause the contraction of the muscles of the pharynx to deglute. So I think that different brain areas are being targeted, as shown by shrinkage of the brain in some UK bank studies, which is nothing wrong with it. But diagnosing a condition after it has caused damage, okay, is I don't. I would like to say it's important, but I would not celebrate it, only because what's the point in diagnosing a disease after the damage is being done? The point is when it is causing the damage, when it's causing that injury and the biochemical injury is going on there, give neuroprotective drugs, give neuro anti-inflammatory drugs, give drugs that could be targeting the neurotropic presence of the virus. That actually I would like to celebrate, okay, and then there would be no changes on CT scan and MRI. So my listeners, I would say, don't think that the damage is only done when your MRI or your CT scan comes with a report that they see some damages. The damages are ongoing. They may be ongoing, and you have to address them, okay, when they are ongoing. Thank you.
Thank you so much. And we have a couple more questions. And are you okay for taking them?
Yeah, I'm okay.
Good. So, what type of drugs should be selected for neuro-COVID? It's very common now, and we see that with Omicron as well, that neuro-COVID become more common rather than it was in Delta and
Mm.
at the beginning of pandemic.
When the answer to this question would be at some point where the presentation was going on, where I said that neuro anti-inflammatory drugs could be the ones which would show result. So neuro COVID, the neurological deficits are not mostly caused by the virus causing the damage of the neuron. It mostly, as published research says, that inflammation is the cause. So if we could prescribe our patient a drug, okay, which actually crosses the blood-brain barrier and prevents the inflammation, ongoing inflammation in the brain, okay, it would be a huge success in preventing neuro COVID in long COVID patients. Sorry, cannot hear you.
Sorry. We also have another question from the audience. And would you say MCFS is very closely related? As I would say, my long COVID has developed into a MCFS.
For my followers, okay, and the listeners, and the greater audience in general, I would like to tell you something. Whatever you heard me today saying about long COVID, okay, if I would select a percentage, okay, anything above 90 would be equally applicable to patient with ME and CFS. Okay, so the more I tell you one thing, long COVID gave us an excuse to help you guys as well. Like I'm very except the sorry when I say that. Okay, we feel very sorry that we didn't address you in the past, but with long COVID, anything that we discover, okay, we will test it equally in this condition, okay, and keep you updated with the results so that you can benefit equally with our research.
And then maybe we will cover the same topic. And will drugs that work for long COVID also work for MCFS?
I'm very optimistic. I'm very
Okay,
optimistic. I'm very
good.
optimistic. And even for the neuro symptoms, okay, what you just heard, any neuro anti-inflammatory drugs, okay, even at this time, somewhere in the midst of the disease process of ME and CFS, okay, I think it deserves a trial, okay, that to see that how much response does this shows.
Very good question, actually. On do you intend to do consultations? And we have heard that groups are inviting you to cities worldwide to visit them, as we saw it in a few of your previous tweets. So, what is the situation?
Honestly, on this, okay, you just like, if I could answer this, I would love to do that. That's the word, because when I sit there and I just like type those lines for the long COVID guys and MECSF guys, like I feel like handcuffed. Okay, at the same time, I feel like I would like to scratch my back. I couldn't do that. I mean, like this is what is needed. Yeah, yeah, why not? Okay, arrangements can be made. Okay, but then you heard me earlier. I'm very much into knowing the mechanism that is causing it. Once I know it, okay, as you saw today, in many cases, okay, now we are very close to actually put the last nail in the coffin of its understanding. Once we do that, okay, consultations are no problem. Group or individual, okay, we can. If it's help, okay, it should come. I mean, like, how do you call it? Is another issue. Consultation, advice, help, okay, or whatever. I'm open to it. Yeah, very much open to it.
Great. Patients need you, and we'll try to facilitate if there will be any intention and time. Yes, and what is the status of your research on what has been funded this year?
No, I mean, like the guys on the Twitter would be smiling on this question, and they know that the funding is like very petty, Okay, it's coming from resources. I've got collaboration in NIH. I've got collaboration with some biotechs now in US and Florida. Okay, to name a few. Okay, Xera and Longigron. Okay, these are some great for what you call as biotech resources that are very much willing to fund me. Yeah, I was in a bit pessimistic. Okay, like few months back, thinking that who is hearing it, but then I've into a good chat with the scientists and their CEOs. Okay, so I'm expecting that a bit of it will be funded, and all credit goes to my long COVID followers and guys who believed in me because they made a word. Okay, and then we can help them back.
Thank you so much. I think we will uh, stop here because we're already going over time. So, Dr. Baig, it's pleasure talking to you as always, and we'll be really looking into more discussions on autoantibodies, and this is really heavily not studied subject which appears in long COVID.
You're right.
And for our listeners, I would like to announce that we're gonna have a third Long COVID Coalition Congress this Sunday at 5 p.m. UK time, which will take place live on this channel, where we will be talking about thrombosis and coagulation issues with global experts. So please follow our channel, subscribe, so you will get announcements when it comes. So Dr. Baig will be there as well, who will be bridging gaps in on this subject. And Dr. Baig, I will rush to say that did amazing research and has got amazing findings for the main causes of coagulation, and he will be talking on that. So please follow that link and learn more on thrombosis and coagulation. This is something that Dr. Baig just recently discussed as number one target for tackling long COVID symptoms. So I will stop now and thank you very much for your time. Thank you for everyone for listening and asking questions and keeping it going live. And please take this information to your physicians, clinicians, friends, share it, and help us raise awareness. You can support Long COVID Foundation by simply subscribing so we grow bigger and more awareness is created about long COVID. So this is all what you can do, and I'm really thankful if you will do that. So thank you so much, and have a nice the rest of the day. Bye
Thank
bye.
you.